Next, let's say about 20 to 25 minutes, I'll try to wrap up fast. I will give you an overview of diagnosis and management of heart failure, and we'll see what comes through that. When I heard Edwin talk, the first thought I thought was I must talk as slow as Edwin. It's going to be very difficult. I'll try to talk slowly. Okay, now what happens in heart failure is that this is what we have seen over the years. Whenever we talk about heart failure, about when I was doing my MBBS, most of the time when we used to call a consultant, the calls were all for chest pain, 1 hour diaphoresis, then acute myocardial infarction. But nowadays, we are getting more and more cases who are diabetic, hypertensive, acute breathlessness with some non-specific ECG changes. So this is the pattern in which we are seeing cases of late. And if you look at the course of time between 1960 and 2010, you see that this picture of myocardial infarction mortality has come down ever since the PTCA, the streptokinase came in and all these things started coming in. But what's going up over years is the amount of PCIs, which is the PTCAs, and the heart failure hospitalization, which is exponentially growing. It looks like the COVID curve during the pandemic. So that's what's been happening. Why are we so worried about heart failure? Simplest thing, within 5 years, 50% of the patients with chronic heart failure are dead. So 50% of the patients are going to die within 5 years. And that is the reason why we are mainly worried. So what is this heart failure? Simply speaking, the American College of Cardiology defined it as a clinical syndrome, basically, that can result from any structural or functional disorder that impairs the ability of the ventricle to fill with or eject blood. Now, remember, it's not only the filling or the ejection. It could be any of the two. Ejection is the ejection fraction. Filling up is going to be the diastolic function. Now, the Europeans gave a much simpler definition. It's a clinical symptoms and signs secondary to abnormal ventricular function. This definition still holds good. So basically, it's a clinical diagnosis of heart failure. So how do you investigate? The usual blah, blah investigations? ECG can come in handy during an acute myocardial infarction, but what comes into the clinical picture more often is the chest X-ray and the echocardiogram. Look at this chest X-ray, classically clearly showing a beautiful cardiac enlargement here in this. And look at the echocardiogram in this picture. You show a clearly dilated heart, a left atrial enlargement. The heart is hardly contracting. This is going to be fairly easy. Now, these are all conventional diagnosis, conventional investigations that we keep talking about. But nowadays, what do we do clinically? We start looking at the BNPs and the NT-proBNPs. Now, how relevant is this BNP and how important is that? Now, today, if you look at the NT-proBNP, which is more often being done, if you're not in an acute setting, 125 is normal. If you're in an acute setting, 300 is normal. Up to 300 is normal. So if you have any value more than 300 is going to be abnormal. It is going to support your diagnosis. Mind you, there are several other causes of elevated natriuretic peptide. If the patient is old, acute coronary event, renal insufficiency, pulmonary embolism, RV dysfunction, atrial fibrillation, pulmonary hypertension, anemia, high output stage, patient is grossly anemic, NT-proBNP is going to be elevated. Sepsis is going to have it, mitral regurgitation, whether it's a volume overload, all these are going to be elevated. So you must remember all these factors when you start interpreting NT-proBNP, because of late, I keep getting so many references telling me that the NT-proBNP is elevated. They look at it, the patient is in sepsis, NT-proBNP is elevated, doesn't carry any relevance. But the other side is a very interesting side where you have lower natriuretic peptides, even though the patient is in pulmonary edema. One is obesity. It can be falsely low. Flash pulmonary edema, there is not enough time for the NT-proBNP to go up. Pericarditis looks like that. Genetic polymorphisms, very rare, but end-stage cardiomyopathy. The burnt-out cardiomyopathies do not have an elevated natriuretic peptide. That's a very important differential diagnosis you must have at this point of time. Now, today, whenever we diagnose heart failure, we are talking about POCUS, or point-of-care ultrasound. Now, point-of-care ultrasound in the emergency is a very important point, and you must remember, it is very easy to diagnose pulmonary edema if you do a lung ultrasound. Now, look at this. You can do a lot of things if you have an echo machine or an any ultrasound machine. You can look at the cardiac contraction. It could be a right heart failure, the RV is enlarged in this. It could be a left heart dysfunction. You could show the IVC being dilated, the hepatic veins being congested. And look at these lines. These vertical lines that are clearly seen are the shape of the lung water, as we call it. These are the B lines. The vertical lines that keep drawing from above downwards, continuously going. These are the curly lines. These are the B lines. And B lines more than 3 are abnormal, and they are suggestive of a pulmonary edema. So in the emergency, you can make a very accurate diagnosis of pulmonary edema. If you have a pneumonia, you don't have these, you have a homogeneous opacity. So it is very easy to diagnose if you just know how to do a lung ultrasound. This point-of-care ultrasound is now becoming a new diagnostic modality for management. So how do you classify heart failure with the heart failure? In terms of echocardiography, there are 3 diagnoses. The heart failure with reduced ejection fraction, the mid-range ejection fraction, and the preserved ejection fraction. The classic heart failure is the one where the ejection fraction is less than 40%. When you have a classical heart failure when the ejection fraction is more than 50%, you call it heart failure with preserved ejection fraction. But here, and it's very important to show an elevated natriuretic peptide to say that it is cardiac failure. So you have an elevated peptide along with an ejection fraction that is normal, you call it heart failure with preserved ejection fraction. Now, this middle category of 40 to 49% is called mid-range ejection fraction. But the new terminology that we use for that is the mildly reduced ejection fraction, because this tends to behave more like the heart failure with reduced ejection fraction than those with the heart failure with preserved ejection fraction. Sri Vidya Shankaran, I think you should mute yourself. All right. So the next one is, which is more important, the heart failure with preserved ejection fraction or the heart failure with reduced ejection fraction? Now, if you look at the life expectancy in the US, the blue bar is reduced ejection fraction and the gray bar is the preserved ejection fraction. Look at the life expectancy by different ages, all are looking similar. So any heart failure, whether it is going to be preserved ejection fraction, reduced ejection fraction, or mid-range ejection fraction, fares equally badly. And it is very poor prognosis ultimately. So when it comes to treatment, we are spoiled for choices today. We used to talk about diuretics only those days, but today what are we looking at? The primary treatment has been the ACE inhibitor or the ARBs, the beta blockers and the MRA, strongly supported by several trials that are given above these data. But today we are looking at newer medication, the neprilysin inhibition or the ARNI, the sacubitril valsartan combination, the SGLT2 inhibitors, the vericiguat, which is a guanylate cyclase potentiator, and the ivabradine, which just reduces heart rate without changing the contractility of the heart. So these are newer drugs. So how do you go about treating and how do you go about selecting which drug for this? Now, how did this evolution come up? Initially, the first drug that came in was the ACE inhibitor and the ARB. The enalapril trial started coming in. When that was coming in, there was a 20% reduction in the sudden cardiac death. Now, when the beta blockers were first studied, they found out that in addition to the ACE inhibitor and ARB, there was a 42% overall reduction that came up in addition to the beta blockers. The MRA trials, basically the spironolactone and neprilysin, subsequently showed, in addition to these two, subsequent 19% increase or reduction in sudden cardiac death was found. Now, finally, when the ARNI came in, compared to the enalapril, there was a 22% reduction in the sudden cardiac death, clearly showing we are going towards better and better medication and treatment. So the American College of Cardiology came up with this protocol for symptomatic heart failure and said, all patients must be on an ACE inhibitor, ARB, or an angiotensin receptor blockade. ARNI is a preferred drug. Clearly, ARNI is a preferred drug. Evidence-based beta blocker should also be used. Now, what is the evidence-based beta blocker? Only 3 beta blockers have evidence. The carvedilol, metoprolol, and bisoprolol. You can't use the other beta blockers. So you can use either carvedilol, metoprolol, or bisoprolol only, not the other beta blockers. Once you finish this, the next step is to look at the kidney parameters, creatinine less than 2 and a potassium less than 5. You must start all the patients on an aldosterone antagonist, meaning eplerenone or an spironolactone. If the renal parameters are still good, EGFR qualifies, next step is to add an SGLT2 inhibitor, like the dapagliflozin or the empagliflozin. Diuretic comes into the picture next and only in case of symptoms. Now, what is the role of diuretics? In the outpatient setting, all the patients do not need diuretics because it does not offer survival benefits. There is no mortality reduction when you give diuretics. It just gives symptomatic relief from congestion. So what's better is to put the patient on a decent amount of fluid restriction like 1.5 liters and a salt restriction depending on what the patient is requiring. Monitor the weight daily. If you have a 0.75 kg weight gain per day or a 2 kg per week weight gain, step up the diuretic and get the patient back, because you're going to pick up the edema before the peripheral edema happens, just because the edema happens only after nearly about 2 kgs of weight gain. Before that, you can pick up the patient if you monitor the weight every day. Start diuretics there, and that will prevent an edema from happening in these patients. Now, should all patients receive diuretics at discharge? Now, look at just 2 parameters. Patients with pulmonary congestion. Pulmonary arrhythmias, if you do not have pulmonary congestion, if you give the diuretics, they fare worse. If you have lung congestion, definitely they benefit. Look at the combined endpoint in terms of all-cause mortality. Again, there is no benefit if there is not much of significant congestion. What about lower extremity edema? Without edema or without congestion, if you look at it, again, diuretics are harmful. Not even beneficial, not even neutral. They are harmful because loop diuretics fare worse. So don't unnecessarily abuse diuretics. You will find most common prescription. Anybody with ejection fraction less than 40%, 45%, start them on a Lasix, start them on a spironolactone. It is not useful. You in fact harm the patient because of the electrolyte disturbances that happen along with them. Next, we look at not only the diuretics. If the diuretics don't work, you can always start these patients on combination of hydralazine is the isosorbide dinitrate, and finally there is a small role for ivabradine also. Now, beta blockers are one of the very important drugs, and how much of beta blockers do you have to give? Now, this is a beautiful study that came up called the MOCHA study. Now, you look at this, as the dose of beta blockers goes up from 6.25 to 25 milligram twice a day. Now, look at this, the ejection fraction actually improves. And if you increase the dose, the mortality comes down. Now, this is very, very important. You try to go to the maximum tolerated dose of the beta blocker. It is very, very important. Don't give beta blocker for the sake of giving beta blockers, because it has to be given at the correct dose, because incremental benefit is there when you go for a higher dose. So how much should you give? If you're going to use bisoprolol, 10 milligram. If you're going to use carvedilol, 25 milligram twice a day if your weight is less than 85. If your weight is more than 85, 50 milligram twice a day. I've never used this, but I've used 25 milligram twice a day in patients. If you're going to use metoprolol, push it up to 200 milligrams. And if you don't get a heart rate, you tolerate beta blockers, maximum tolerated dose of beta blockers are given. If you still not able to achieve a good heart rate, if the heart rate is more than 70, then you start giving ivabradine. Ivabradine is not recommended for all the patients. It is recommended only following a maximum tolerated dose of beta blockers. Still the heart rate is more than 70, you give beta blockers. Now, how low can you get? The heart rate should be titrated to 50 to 60. Now, this is 50 to 60 from the American College of Cardiology. There's a clear guideline that has said you try to get to a heart rate of 50 to 60. It's not easy to get, but anything less than 70, I think, is reasonably acceptable. But how well are we treating our patients? This study from last year published showed that the usage of ACE inhibitor and ARB is going to be something like 37% do not get these drugs, 21% do not get beta blockers, 85% don't get ARNI, and 63% do not get an ARNI. But which number of patients get the 100% target dose? The best seems to be the MRA, because that's a very easy dose to titrate. Only about 26-27% are able to get, but none of the patients get a full dose of ACE inhibitor, ARB, or a beta blocker. It happens from 1% to 18%. Very, very abysmally poor data that is seen. Now, why are we pushing this? Now, look at this slide. There is a cumulative benefit of all these drugs. If you don't give any of these drugs, the 2-year mortality is 35%. You start them on ARNI, it comes down to 25%. You add a beta blocker, 16%. You add an MRA, then it comes down to 11%. You add an SGLT2 inhibitor, it further comes down to 9.5%. Now, you must remember, you try to get all these 4 drugs on board. Now, we have been talking a lot about the SGLT2 inhibitors, which are actually diabetic drugs. Edwin also made a passing mention about SGLT2 inhibitors. They actually promote a sodium and glucose co-transport inhibition. So what happens? Glucose and sodium are excreted in the urine. Now, how does this drug clinically translate? There are 2 major trials, the dapagliflozin trial, the Emperor trial with the empagliflozin, which showed that the combined endpoint came down by nearly 25% in both these studies, which is hospitalization for heart failure and cardiovascular death. The hospitalizations came down by nearly 30% in both these drugs, and mortality also came down by about 10 to 20% in both these group of drugs. Now, clearly, these drugs, the interesting part is that they are not only useful in diabetics. Now, 50% of these patients were found to be non-diabetic. So even in a non-diabetic patient, you have to start SGLT2 inhibitors, because over and above the conventional therapy, you have a nearly 18% reduction in mortality. So all the patients should be on these drugs. So how do you titrate these drugs? On day 1, if you start ARNI, beta blocker, MRA, and SGLT2 inhibitors, the advantage of SGLT2 inhibitors is a fixed dose. Either you give a 10 milligram empagliflozin or 10 milligram dapagliflozin, no change in the dosage, just 1 dose start. MRA, you tolerate it, you titrate the dose, you can go up to 50 milligrams of spironolactone. Beta blockers has to be titrated starting from day 7. Within 1 week, you can start titrating 7 days, 14 days, 28 days, and every 7 days you can titrate. When you start using an ARNI or an ACE inhibitor, you have to wait for 2 weeks before pushing up the dose. That is the protocol for increasing these drugs. Now, how is the hypotension? Because the biggest problem in heart failure is managing the blood pressure. If you look at the blood pressure, the biggest problem is the hypotension. And the common thing that we do is when you get 100 or 90 systolic pressure, we keep telling them that there is a problem. Now, what exactly happens is that we do not look at hypotension simply as the value. It is symptomatic hypotension. I have patients who are walking around very well with all the drugs with a 90 systolic blood pressure. That's the blood pressure they tolerate very well. So go for a symptomatic hypotension as the goal for therapy. And there are a lot of these drugs like the nitrates, the calcium channel blockers, the diuretics. Most often we dehydrate the patients and produce hypotension. So look at the fluid status and don't unnecessarily flog them with all these drugs. You will get a better blood pressure to titrate these drugs. Now, how soon these drugs act? All these beta blockers, MRA, SGLT2, ARNI, all start acting fast, of which you will notice that the DAPA and the Emperor trial showed that nearly 50% of the benefit happened within 4 weeks. So within 28 days, there was a statistically significant reduction in the heart failure hospitalization. So the benefits for these drugs, like the SGLT2 inhibitors, is very, very early, and you can start using these drugs very well. Now, this is the algorithm for usage of all the drugs. The diuretics come in only when required. Basically, all the drugs should be on board. Now, this is the final summary of heart failure treatment. MRA is going to be used, beta blockers is going to be used, diuretics only if there is congestion, SGLT2 inhibitors for all the patients, a combination of ARNI, which is the ARB plus the neprilysin inhibitor for all the patients. If they still continue to be intolerant to these drugs, or if you can't give these drugs for various reasons, then you use isosorbide mononitrate and a hydrolyzine combination. Now, there are 4 interesting lines here. Remember this. If the patient is in atrial fibrillation, add anticoagulation. You can add a newer drug called vericiguat. I'm not going to that today. Digoxin can be useful if there are persisting symptoms, because digoxin now has come in a big way, especially in atrial fibrillation. It is said to be as good as beta blockers in heart failure with atrial fibrillation. And IV iron is a very often forgotten point. I want to have one slide on that. Even if your hemoglobin is less than 15, look at the serum ferritin levels and the transferrin saturation. If your serum ferritin is less than 100 or between 100 and 300 and the transferrin saturation is less than 20, they will benefit from serum iron. The iron is going to be given as an iron ferric carboxy maltase, and this is going to be given parenterally as 1 gram. And you can repeat this after every 3 to 6 months. Symptomatically, fantastic results are found. I use it routinely, and it is very, very beneficial in these group of patients. So you start giving parenteral iron as a single dose, it works very effectively, and symptomatic relief has been found. Now, looking at the drugs that we saw so far, if you initiate, dose escalate, dose de-escalate, and discontinue, the worst is going to be discontinuation. The outcome is going to be worst if you discontinue a drug. Look at the hazard ratio for hospitalization heart failure. If you discontinue a drug like ARB, it comes to 3.16. Initiation comes to 2.62, while for ACE inhibition, dose escalation, it comes to 1.71. So you should remember, it is not only the initiation, but the escalation is also important. De-escalation, it increases the hospitalization heart failure, but you wait for some time and escalate again. You come back to a good point at this point of time. So it is going to be significantly useful to give adequate dose. But there is a new category called heart failure with recurring ejection fraction or improved ejection fraction. Some of these patients, you start these 4 drugs, the ejection fraction improves and they normalize. So what do you do to those patients? Do you stop the drugs? No. Because if you stop these drugs, the recurrence rate is 44%. So you have to continue the ACE inhibitor or ARB or the ARNI, the MRA, and the beta blockers. All these have been studied, and you have to continue these drugs. If you don't, you're going to land up with a problem. I'll give a few slides on heart failure with preserved ejection fraction. One thing you must remember with preserved ejection fraction, it's not a single disease entity. It is a multimorbid disease where there are several other factors. Look at this. Lung disease, iron deficiency anemia, renal dysfunction, aging, obesity, psychiatric disorders, hypertension, valvular disorders, elevated blood pressure, patients with autonomic dysfunction, atrial dysfunction, and a left ventricular hypertrophy. All these put together put up comorbid conditions that come and produce a heart failure with preserved ejection fraction. Several times, these older women who are obese, hypertensive, with left ventricular hypertrophy, with an unexplained dyspnea, are all having heart failure with preserved ejection fraction. Now, if you look at it, the echocardiogram is very important. If you look at the common echo reports, they say heart LV diastolic dysfunction, grade 1, grade 2, grade 3. That is absolutely wrong. You have to classify the diastolic dysfunction clearly with the tissue Doppler imaging, where you look at the E by E prime, septal or lateral E prime, TR velocity, and the LA volume index. If you look at these 4 parameters, you have a clear normal diastolic function. If there are 2 positive, it's indeterminate. 3 to 4 makes a clear diastolic dysfunction. None of the labs will give you these values. If you insist and get it done, you're going to have a better diagnosis of diastolic function. And if you club it along with the NT-proBNP, you have a very good diagnosis in clinical practice. One of the simplest drugs that has been found to be effective is Spironolactone based on the TopCat trial. In this group, there was one subset of patients who had significant benefits. The obese diabetics with the inflammation were significantly benefited from Spironolactone. Those group of patients really benefit from Spironolactone. And this group, if you have a diabetic obese with heart failure with preserved ejection fraction, Spironolactone is going to be useful. Now, recently, 2 trials called the SOLOIST and SCORED showed heart failure with preserved ejection fraction responds very well to a new drug. We have so far seen SGLT2 inhibitors. There's an SGLT1 and 2 combined inhibitor called Sotagliflosing. Now, this drug is not yet available in the market, but this has been shown to have a significant reduction. Now, you look at the hazard ratio, it is going to be nearly 36%, 37% reduction with a significant p-value. Now, this is probably going to be the new drug that is going to be coming in. The other interesting drug that came up was the SGLT2 inhibitors. Apart from this, is in the ARNI. There was a negative trial called the Paragon trial, but in some subsets of patients where the heart failure with the lower grade of ejection fraction, heart failure with preserved ejection fraction, where the EF was slightly on the lower side, showed some benefits. And in December 2019, the US FDA said they had looking into it and a critical factor. And interestingly, 2 weeks ago, the US FDA, for patients who had a ejection fraction that was below the median, that is less than 60% or less than 57% in this. So they say that heart failure with preserved ejection fraction, but the EF is less than normal, less than 60%, or probably the mid-range ejection fraction, those patients are going to benefit. And US FDA has approved this drug. So the first drug approved for treatment for heart failure with preserved ejection fraction is the ARNI. So if you have a diagnosis of heart failure with preserved ejection fraction and the EF that is less than 60%, you can start treating these patients with ARNI that is going to have benefits. So finally, to summarize the treatment of heart failure with reduced ejection fraction, going back, there are 4 pillars of management: the ARNI, the beta blockers, MRA, and the SGLT2 inhibitors. Now, if you combine all these 4 drugs, the number needed to treat over 24 months to save 1 life is just 4. You just treat 4 patients with these drugs, you're going to save 1 life, which is fantastic for a disease that is going to have a 5-year mortality of 50%. So if you are going to treat your patients, treat them adequately, these 4 drugs, and the conventional sequencing has gone in, and based on the current diagnosis, the sequencing that is going to be proposed for 2021 is this. You don't start ARNI, you start any patient with beta blocker and SGLT2 inhibitor first. The next set is to start ARNI and finally the MRA antagonist. Now, this is going to be the treatment for the future, and this is how we're going to treat these patients. The final take-home message: heart failure with preserved reduced ejection fraction is a very significant problem. 50% of all these heart failures die within 5 years. Heart failure, chronic heart failure with ejection fraction less than 50%. Try to keep a heart rate of 70 with beta blockers and ivabradine. ARNI is going to be the better among the ARBs and ACE inhibitors. MRA for all, SGLT2 inhibitors for all, small role for digoxin and nitrate and hydralazine. Don't stop if there is improvement. You have to continue because there is a 44% recurrence rate. Heart failure with preserved ejection fraction, the new approved drug is ARNI, but probably the other drugs that are going to be beneficial are the SGLT2 inhibitors and Spironolactone. I think I have given you enough insight, but remember, whenever you treat heart failure, remember Swami Vivekananda: arise, awake, and stop not until the goal is reached. It's very important to reach a good goal because that is when these drugs are effective. Thank you so much for the patient listening. And